on our next episode of Raised Plow. We're very honored to have Dr. Jeffrey Velotta, a thoracic surgeon who has a specialty in diagnosing and treating patients with mesothelioma. Doctor, welcome. And could you just give us a little bit about your background and describe what your current position is?
Yeah, happy to be here. Thank you, Joe, and thank you for raising awareness about mesothelioma here today. So I'm a thoracic surgeon at Kaiser Permanente in the Northern California system, where roughly 40% of the insured population is insured by Kaiser. But Kaiser kind of is the big HMO health system for all of California, including Southern California. But we also have Kaiser in the Northwest, so in Washington, in Oregon, in Hawaii, Maryland, Virginia, DC, and Georgia, as well as Colorado. So kind of a big kind of integrated network across the United States. And essentially what we do for mesothelioma, I run the mesothelioma program from the surgical side. I also have a colleague of mine, Dr. Marie Suga, who's a medical oncologist, who runs kind of the multidisciplinary tumor board with me. So we have our tandem team kind of look at all mesothelioma cases in Northern California. And then we also see outside cases, but really I want to focus more on the different Kaiser outside cases, meaning so if somebody in Seattle in the Kaiser system, which they don't have the mesothelioma expertise about whether or not they should do surgery or chemo or immunotherapy, they can refer to us and we can virtually go over those cases. So that often happens from Hawaii, for example. Hawaii, they don't have as much mesothelioma experts out there. So we will see all within the Kaiser system, all different Kaisers. We can weigh in virtually through a multidisciplinary tumor board setting virtually, as well as look at all the images virtually. So kind of the main hub, if you want to call it, in the Kaiser system is in Northern California, whereas Dr. Suga and I have been kind of whether it's voted or whatever you want to call it for the last 8 or 9 years. Actually 10 years, last 10 years have been running our kind of specialized mesothelioma program for pleural mesothelioma. So this is all pleural mesothelioma. So that's kind of how we work the program here.
Okay. I wanted to ask you a couple of questions about your mesothelioma center, but before I do that, can you just tell us a little bit about your education and training background, and particularly
Yep.
the significance of being trained in part at the Brigham in Boston and the role that plays
Yeah.
in mesothelioma?
Yeah, thanks for bringing that up, Joe. So they actually have two training episodes where I kind of got the best of both worlds in a way. So I did general surgery training at UCLA, and did a lot of rotations and mentorship under Bob Cameron, who really kind of perfected a lot of the pleurectomy and decortication. So I saw a lot of that even as a general surgery resident, even before I went into cardiothoracic, kind of seeing that he was very big in pleurectomy at the time when EPP dominated back in the 2005 to 2010-ish region. So I really got to see Bob Cameron and operate with him a lot on meso cases and actually go to his clinic even when he had that institute. So we'd see clinic patients every week too. So saw that aspect. And then the real key for me but it was nice to have that background in mesothelioma through attending a lot of the seminars that Dr. Cam used to do. But then really it was at the Brigham. So at the Brigham Women's Hospital, which I know a lot of your listeners know, Dr. David Sugarbaker, was there during that time period. And I was there from 2012 to 2014. And that was, where back in the day when Dr. Sugarbaker was there, that was when we were doing 5 to 6 of these a week surgeries and had full-blown clinics of just, dozens of patients, whether they were surgical or not. We were just seeing patients all the time in his clinic. It was really the big, mecca where we were doing about 200 cases a year, the biggest mesothelioma center in the world. And who knows now with everything, the way everything is, I don't know if you could say any place is the busiest anymore. But back then, the training under Dr. Sugarbaker and then later carried on by Dr. Bueno was really kind of the creme de la creme of how to do this type of surgery. And again, so I learned a lot about extrapleural pneumonectomies, which can still be done, although more rare, but you need to know how to do that surgery if you ever need to do it for mesothelioma. So I think that's a lost art that nobody sees anymore. So we were able to do that there. But then halfway through my training, there was a big impetus because a lot of the new data, including coming out of the Brigham and Women's Hospital, that pleurectomy and decortication, right? So saving the lung sparing surgery was actually doing very well. So we really did a shift so I was able to feel that I got the best of both worlds, that we were able to do half and half essentially at that time. And if you're doing 200 cases a year, right, more than anybody, and for 2 years, that's the most you'll ever get anywhere. So I was able to really get a good basis of the pleurectomy and decortication with Sugar Baker, as well as with Bob Cameron at UCLA, and then also to know how to do extrapleural pneumonectomies, because they are still sometimes required, and you got to know how to do it if you get in trouble with a pleurectomy and decortication in terms of bleeding or things like that. So I think getting that aspect of it was really the only way, Joe, that I would consider myself saying when I came out of fellowship and came back to the Bay Area in 2014 to do mesothelioma. If I wouldn't have had that training at the Brigham, there's no way that I think that nowadays, how complex it is and everything, that you can feel comfortable. Again, this is my bias of doing surgery or saying you're a specialist, right? Everybody says they can do mesothelioma or do that. But if you haven't been trained at some of these places, whether it's an MD Anderson, Memorial Sloan Kettering, or Brigham, where there's only a few places in the country where you can get a lot of this, and UCLA back in the day, I think it's hard to say that you can feel specialized and do this surgery because it is so complex and nuanced. So I do feel like I was lucky enough. And that's kind of why I kept with that expertise, because of the training that I got there in Boston.
Yeah. And for our listeners who may be new to mesothelioma and the various treatments, the institutions that you're talking about, the surgeons you're talking about, Dr. Cameron, Dr. Sugarbaker, and the Brigham, Dr. Roosh, and Memorial. These are since you're out in California, I'll say these are the Stephen Currys and LeBron James of mesothelioma surgery that really developed the techniques and trained so many wonderful surgeons like yourself to be able to do these procedures. So can you tell our listeners a little bit, and this is following up on the point you made, that you're able to provide your expertise to Kaiser locations, the importance of people with mesothelioma getting treated at a mesothelioma center or by a mesothelioma specialist, by you, versus people who have, say, prostate cancer or breast cancer or things like that.
Yeah, thank you, Joe, for highlighting that. Mesothelioma, as we know, is super rare. That's one of the main issues, that none of us really ever see it in our lifetime. You can be a cardiothoracic surgeon and never see mesothelioma in your lifetime, because there's only, as many listeners may know or may not, but anywhere from 2,000 to 3,000 cases in the world a year. And again, a lot of those are not potentially maybe even surgical, or not, or even be evaluated by a surgeon. So, and this is in the world per year. And so, and we know half of these patients may even be over the age of 80 or 85. So they may not want treatment anyways. So with that being said, this is a small finite amount of people that you're seeing, and then even a smaller amount of group that even can tolerate a surgery. So you can imagine, if you're only seeing it once or so a year, how can you consider yourself knowing exactly how to do this type of surgery? If you're only seeing it once or twice a year, versus prostate, a urologist may see 50 a day in any place, right? Because it's the most common cancer in men. Whereas mesothelioma is one of the most rare surgeries we see. But on top of that, Joe, not only do you see very rare amounts of this complex cancer, it is an aggressive cancer, right? It grows and it invades around the lung. And so it makes it complex in that it's not just, oh, a little itty bitty nodule you can just pop out and anybody can do it, right? So that brings me to the surgery. In our field, in cardiothoracic surgery, in terms of thoracic oncology surgery, mesothelioma surgery is considered the most complex and the most morbid and the biggest open type of surgeries. In fact, it's probably one of the last surgeries that we do that is classically still open, big thoracotomy, big incision on the side, removing part of your rib, opening your whole chest on the side. Okay. Even lung transplants now can be done robotically, right? With mesothelioma, the way it grows on the outside lining of the lung, it invades everywhere, nook and cranny. It is not feasible, and we do not us in the field that know this field do not recommend, say, a robot approach or a laparoscopic approach. You have to go old-fashioned way. So it is the last of the last, where you got to get your hands dirty and get in there and take big chunks of concrete tumor off of vital structures like the aorta, the esophagus, the heart, and the lung itself. So all of these things that if I didn't scare the audience, I'm not trying to scare y'all. It's just try to say that like with all that I just said, yeah, you want somebody that does a lot of these and that sees it because you got to know how to remove it because it's already hard to remove it. And then if you want to remove it, you got to remove it safely. So you'll get out of the operating room and then you'll recover. And if you recover from the surgery, we all know that you'll live a much longer life with the addition of surgery and chemotherapy and immunotherapy. But if you don't go to a center that does a lot of these, that you have the anesthesiologist, the nursing staff, the oncologist, the surgeon themselves that do a lot of these, you're going to struggle through the surgery. And that's what you hear a lot on different trials, on different websites, on different, all the horror stories on Google. This is the one cancer that I can say, Joe, and even lung, esophagus, those, I think pretty much any thoracic surgeon, those, there's some that are better than others, but that's not a big deal. Okay. For meso, there's only a few people that we can even say now in the country in the United States that really have a good inkling on doing this. That's what's scary. This is a dying field that should not be dying. And that's why we need to be on these podcasts to let people know that there's still people out there doing this. But again, you need to find those people because if you don't find those people, you'll often get a wrong answer. And I'll flat out say that there are incorrect answers out there by people that don't know the field, that don't feel comfortable doing the surgery, or don't even want to take the risk of the surgery. So it's very easy to say, no, 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 you're not operative, or no, 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 we're not going to do that. And so that's what we're seeing now in this day and age with Mars 2, especially with that randomized trial that has a lot of issues. But regardless, there was already people prior to that trial, Joe, that didn't want to do the surgery. They didn't believe in the surgery. They didn't know how to do the surgery because they're not trained in that because everybody's just trained on the robot now. And then now you have Mars 2, you basically brought about 80% more of everybody to the other side, which they don't do surgery. So there's maybe 20% of us left out in the country that feel very comfortable doing this, that know that you can do very well with this surgery, very low morbidity and mortality and live longer. Yet there's very few of us, and yet even more patients that aren't coming to us because you have more surgeons out there and more oncologists that are saying, no, 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 no treatment, no treatment, no surgery involved in their treatment. So we're really at an impetus and a precipice that is really dire. And that's why we did come out with our new statement that we can talk about later.
Okay. So let's dive a little bit into the details. You mentioned earlier these two different types of surgery, the extrapleural pneumonectomy, which sometimes referred to as an EPP, and the pleurectomy surgery, both of which are used for mesothelioma. Could you just give a description of what each surgery is? And then we can talk a little bit about why the pleurectomy is the preferred approach if possible and some of the new studies that are coming out.
Yeah, absolutely. So the main two surgeries, like you said, Joe, is either an extrapleural pneumonectomy, EPP, or pleurectomy and decortication. The main differences that I usually try to tell patients when I describe it to patients or just people out there is that the extrapleural pneumonectomy, the big difference, the big morbidity is that not only are you removing all the pleural lining and all the surfaces around the chest, you remove the entire lung. That's the big difference. An EPP, extrapleural pneumonectomy, you remove cancer, the mesothelioma layer pleural lining, but the lung itself, underlying lung itself, regardless of it's involved or not. Okay. The newer procedure or more procedures that the newer studies show that is less morbid, better survival, and better recovery and live longer with it and get good amount of tumor, just as amount of tumor clearance is the pleurectomy decortication. And the main difference is that we know mesothelioma is not a cancer of the lung. It was always thought before, oh, we can't get it all off. It's going to stay on there. But if you don't take the lung, that's not true. You can actually, that's why you have to know this surgery. Plectomy decortication is essentially doing the same thing as an extrapleural pneumonectomy, taking off the lining, the layer, all the tumor around, but saving the lung. And that's the key difference. If you save the lung, your morbidity, your mortality, everything is way lower. So you're going to have a better recovery when you save the lung. And that's pretty much shown in all the studies now. So I'd say the majority of us out there now, it's pretty much standard now to do a pleurectomy decortication. In fact, I haven't had to do an extrapleural pneumonectomy in about 4 or 5 years, and I do about 20 of these surgeries a year. So it's very okay and routine, if I want to say it, to do a pleurectomy and decortication and save that lung. And that's really the key. Whereas the old school thinking was, there's a lot of tumor on this person that we're not going to be able to peel it off because it looks so terrible and it's so stuck to the lung. It always comes off. And Dr. Bueno will tell you that. Dr. Roosh will say that. I've been on a lot of panels with them recently over the last 3 months. And they verified that with me, and they're the creme de la creme, the gurus. Joe Friedberg, a lot, Dan Miller, they all agree. We all came to agreement and consensus that really you should be doing a pleurectomy decortication if you're getting surgery. It'd be very rare for an extrapleural pneumonectomy. So that's kind of the way I would kind of state it nowadays.
Yeah. And again, just to underscore, the 20 procedures that you do a year, even though it sounds like a small number,
Oh, right.
puts you in the top number wise of surgeons doing these types of procedures. So one other
Correct.
question I wanted to ask you about the pleurectomies that you do, and it might be helpful for our listeners to um, get a little background on this, is a number of surgeons who do these procedures often add in some other component. Dr. Friedberg, who you mentioned, has experimented with his photodynamic therapy. Dr. Sugar Baker and Dr. Bueno like to use this heated chemotherapy. When you do your procedures, do you do any of these adjunct therapies with them?
Yeah, so actually I do. And I do a newer one that there actually is some clinical trials out right now that I want to say actually Dr. Freeberg is looking at, but it was actually came from studies in the UK, and that's with betadine. Betadine in the lab actually kills mesothelioma cells. And then when you heat it, even more. So I use heated betadine bath. It's no side effects at all. It's just betadine, right? It's clear antiseptic stuff. But I don't do it for the antiseptic part. I do it because it's got tumoricidal effect, meaning it kills mesothelioma tumor cells itself. You heat it up, so it makes it more active as well. So instead of the toxic heated chemo part of it, and the heated chemo part they have to do for an hour causes more kidney failure, causes a lot longer length of stay, all that. So that's why I don't like to do that. Plus, it hasn't really shown a proven benefit that it improves survival. So whether you use it or not is totally the data doesn't show there's a benefit really for long-term survival with the negative side effects. So that's why I don't like using the heated chemo, even though we do that at the Brigham. It's okay to do that, but it just adds another hour and a half to the surgery. Plus it adds increased length of stay and a little bit more renal failure because the chemo, even though it's just localized to inside the chest, it does seep out and the kidneys do try to excrete it. So they do have some kidney issues afterwards. So with the betadine, I don't have the side effects of any of that you see, no increased length of stay, no kidney problems. Plus you get that tumoricidal effect that I think you get based in the lab. Now, do I have a long-term study on that yet? No. That's something that is being looked at in a clinical trial, but I don't think it's definitely not going to hurt you. And I think it can only help. And it doesn't add much to your surgery. So that's what I do. And I've been doing that for a while now. And we'll see. I'm compiling the data, but I don't have long enough data to say, as you know, there's so many nuances with surgery and chemotherapies that we add later on through, systemically, and immunotherapy, which is really playing the main part of living longer, right? So it's hard to tease out the betadine right now, and that's why it's been hard to tease out heated chemotherapy. It's even been hard to do the photodynamic therapy. So whether you do or not, I don't think that you should choose your surgeon based on that. But you just have to know if your surgeon does do heated chemo, because that's kind of the more common one. Just that the side effects, and as long as you understand those side effects that those could happen, I think it's fine to do it. But that's one of the reasons why I don't do heated chemo. I like heated betadine.
Excellent, excellent. You mentioned earlier the Mars study. As you know, there's a big debate going on in the mesothelioma community about which treatments are best for which patients. Can you explain a little bit about what the Mars study is, what it showed, and how you and other surgeons have responded to it?
Yeah, so I'll step back a little bit just for the context for our listeners. What Joe was referring to is classically the Mars 2 trial, which is the one that recently came out of the UK, a multi-center randomized controlled trial in which compared getting chemotherapy patients with mesothelioma getting chemotherapy alone and no surgery versus getting chemotherapy first, followed by a surgery, a pleurectomy and decortication, followed by plus or minus chemotherapy afterwards. And when they compared those two groups head to head, they found that survival was actually improved with just chemotherapy, meaning survival was worse you died more or earlier, quote unquote, if you had the surgery with it. So they concluded, the authors concluded that when adding surgery to chemotherapy, that does not improve survival, and that may worsen your overall survival, and suggesting that they just recommend no more surgery. Kind of a blanket statement on all of that. Now, with that being said, that caused a lot of divide in the surgical world and in the medical oncology world too. And that you now have one side or the other, meaning sadly. So because of that study, there are many people that now do not offer any surgery no matter what. 35-year-old, 40-year-old, whatever. Patient wants it. We used to do it before this trial. They still won't do it. Randomized controlled trial data is considered level 1, level A evidence because it's supposed to be randomized and controlled and non-biased, showing surgery was worse. So there are some people on that side of the fence, right? And that is generally what is being done in the UK, in Europe. Generally, surgery is not offered as a routine in a fashion. However, in the United States, we've always been a little bit more pro-surgery. But now with the Mars 2 trial, Joe, we have about 50% more that have gone to the no surgery side. For sure, we see that, okay? So there's 50% of us left out there that still believe in surgery. Now, why is that? I'm not going to go over the 15 reasons why a lot of us think that there was flaws in the Mars 2 trial. We were happy that Dr. Lim and colleagues were able to do a randomized control trial and that it took 8 years and it's hard. But the problem is that they looked at all comers with mesothelioma, the aggressive forms. We know sarcomatoid and biphasic, and those tend to not respond well to surgery. And we've always kind of know that they included that. They also didn't do routine staging, meaning we think of Mars or mesothelioma surgical patients as being earlier stage, whether that be stage 1 and 2 or even 3. Now, they had patients that were potentially and were stage 4. So you can imagine you just take a few extra patients that you operate on that shouldn't have gotten an operation. You add that to them. They didn't die because they didn't die early because of surgery. They died because they had late stage disease and you should have never operated them in the first place. So you're comparing apples to oranges, not apples to apples. And then the other thing is the surgeons that were doing the surgery, nothing against them, but they called high volume surgeons anybody that was doing anywhere from 3 to 5 a year as high volume, which I think classically you could consider that high volume. But in reality, most people that we really think are doing a lot of them are in the 10 to 20. Again, that's to give you context. But they consider those people high volume. And so not surprisingly, also the mortality rates, meaning 9% of patients died within 90 days. So not surprisingly, the surgery group long-term is not going to live as long because a lot of them died within the first 90 days. And so they included all that in the study. So usually the mortality and morbidity within 90 days should be under 2 to 3% after this surgery and experienced mesothelioma has, which is why it's important to see people that do this surgery a lot because we don't usually see them die within 90 days. That trial showed an exorbitantly high amount. So again, all of those results are a little bit biased towards, of course, the surgery group does bad. So if you go with just that study, there's a lot of flaws to that. And so what they teach us in medical school and what they teach us in residency and what they teach us when we go to these high ivory tower centers and learn from other people is that not all research is dogma. Not all studies are perfect. And you don't necessarily have to just go with just because that study said, go with your experience, go with what you feel in your real world practice. And so what the rest of us that are still operating, meaning Memorial Sloan Kettering, the Brighams, the MD Andersons, what I do in the Kaiser system, we, Mount Sinai is another big, Raja Flores and Andrea Wolf, University of Toronto is still doing surgery. But again, University of Chicago, because we actually have all published our own real world data of, hey, it's not a randomized controlled trial, but it's showing in our population of us operating high volume surgeons, all sorts, the mortality and I mean, the survival rates are actually very good and are much better than what we saw in Mars 2. And so we go off of that experience. And so these centers, we're still doing that. But again, the other handful or the other majority of the centers out there in the country, even in the United States, were never doing that many in the first place, didn't have that good of an experience with it. So of course they're going to go, unfortunately, maybe just by what that clinical trial shows. And so there are a lot of programs now in the country that we see are shutting down or no longer offering the surgery at all. Or if they do, they really try to dissuade the patient from even doing it. So I think that's the difference. What you're seeing is that the people that are still doing it know in our own experiences and have published on this, like I said, literally published on this retrospectively, that there are good outcomes when you add surgery. The other thing that I wanted to add, Joe, I don't know if you guys are how you're going to cut this up because I know I talk a lot, but the other thing we're adding, the surgeons that we do the surgery, we never say that surgery alone is going to cure you, or we never say that surgery alone is what we recommend. We always recommend surgery in a multimodal fashion. So that's the key. Us surgeons that are operating aren't cowboys. We know that we can never get rid of all the disease microscopically, right? We know that we can get a lot of the bulk of the disease out, which is good. Everything that we can see, we get out. So we know that improves survival, but we know we need to add chemotherapy. We know we may need to add immunotherapy. We know you may need to add whether it's intra-op chemotherapy, photodynamic therapy, and or radiation therapy afterwards, or tumor treating fields, all of the above. We throw the whole armamentarium at you. So it's all of that together. Those are all of our studies combined, whether you look at it from the Brigham, from here at Kaiser, from MSK, all the studies show that surgery in that multimodal fashion, and when you add it to a bunch of things, your survival is going to be better. So we're always saying that, yes, surgery, but I always tell my patients, don't just think you're going to have surgery with me. You're going to have surgery, and then I'm going to hit you once you recover in, a month or two, chemo, and then immunotherapy. Those patients that can continue on that, which a lot of them do, 60 to 80% can, they're going to live longer. And I always say it's in that combined approach. That's really where surgery really, really helps.
So, I always think that the best approach for people with mesothelioma is to meet with a surgeon like yourself and get an individualized review and opinion tailored to your specific situation. What's your current state of health? What's your comorbidities? What's the how is the tumor presenting? And not have surgeries out of the question, or yes, I'm going to do surgery for sure. And my anecdotal experience is the patients, our clients that do the best are the ones that go to see a surgeon like yourself, who's going to do a workup and help them decide what's the best treatment for them. Um, I know that you're obviously a surgeon, but you mentioned these other treatments like chemotherapies and the immunotherapies, which offer a lot of promise. Can you just describe for our listeners a little bit about these oncology treatments that often go along with the surgeries, what they are?
Yeah, this is where it gets a little confusing, but I think the way to simplify it is the kind of what a lot of us do if we do surgery, it's some type of chemotherapy first. Or is that first, but whether it's before, it's complicated, but whether it's before surgery or after surgery, surgery with chemotherapy is always kind of like a good thing. Okay. Some type of chemotherapy where it's, old fashioned, put it in your vein and it kills cells, good cells and bad cells. So the same kind of chemotherapy that we use for lung cancer, we use similarly to mesothelioma. A recent clinical trial did not show a benefit of doing one way or the other, meaning doing before or after. So depending on who you see, what center you go to, that's why it's good to see a couple opinions and whatnot. They'll have you do chemo first, then surgery. Whereas at my center, including and at the Brigham and at Kaiser, that's where I was trained, we do surgery first and then we do chemo. Okay, so whether you do one or the other before or after the sequentially or whatever, or when you do it doesn't really matter. The key is you do surgery with some type of chemotherapy, and it's usually a dual immunotherapy, or sorry, dual chemotherapy. There's two different types that we usually add to that, and it's very very common. Whether it's cisplatin and carboplatin and pemetrexed, but those are been tried and true, shown to work well, good response rates with surgery on mesothelioma. So that's what I always kind of say is first and foremost, that's kind of well known, right? That's what people most, no matter where you go, chemo plus that. The next question is what's really revolutionized things that we like to add on our patients afterwards, after the surgery and the chemotherapy, because cancer can come back usually eventually a little bit in mesothelioma. Then we add the immunotherapy. So that's the one. It's still an injection, but it's a lot more well tolerated and it's boosting the immune cells to fight more kind of preferentially these cancer cells where it doesn't just attack everywhere in the body. It's not like a cytotoxic poison that you inject in your body. It's boosting immune cells to fight things. And that we showed, even in our data, the patients that did the best had surgery, chemotherapy, followed by immunotherapy. Okay. And then lastly, to make it a little more complex, but again, no, not good proven data one way or the other, is radiation therapy. So there are some places where they'll do radiation even before maybe, and then do surgery, like in Toronto. Or what majority happens, people will get surgery, then chemotherapy, and then usually they're evaluated by a radiation doctor to just radiate the whole radiation around the chest and kind of spare the lung, called IMRT, but it's a specialized form of radiation where they try to less toxicity on the lung and radiate the chest wall, because we know there's always a little bit of microscopic cells left over. So that's when some people will recommend the radiation treatment as a routine. For my practice, for example, I always do as a routine surgery first, followed by chemotherapy, and then I always have them see a radiation oncologist. Okay. That doesn't necessarily mean that the radiation oncologist and the patient will agree to that, because there are side effects, toxicities to the radiation, but I let them have a discussion about it. And about 30 to 40% of my patients will want to do it. The other, 60 to 70% will say, no, we'll just go and continue on surveillance imaging. And the reason that is because no clinical trial or no hard, really good evidence has really shown that radiation improves survival or really helps. And it does have side effects. So it's kind of like one of those things where it's anecdotally can do well in some patients, but again, there hasn't been large, good studies to show that radiation is the key as a routine. We use radiation if it comes back, we see it come back later on, and then zap it. There are some good data for that, but not at, what I'm talking about is a routine. We've already done surgery, we've done chemo, and then it just routinely give you radiation. There hasn't been any good studies to show that you should absolutely do that and it improves your survival. So that's why I give it as an option to a patient, because it is a lot to go through 5 or 6 weeks of every day for, an hour radiation.
Yeah. And I'm assuming one of the reasons why you use chemotherapy first is that most mesothelioma patients get some response from the chemotherapy, and with the immunotherapies, the it not everybody gets a response to it.
Yes. And with that being said, yes, you're right. Chemo, we know responds, especially the pemetrexed responds, there treats the mesothelioma well. We know that there's a decent response with that. Again, I do it after surgery. So, chemo doesn't work as well if there's just tumor everywhere. You give, chemo, it doesn't help as well. But once you've taken it out and then we think you can, have less cells, I think we do think, I mean, I can't prove this exactly because that trial I said didn't show a benefit of it giving it before surgery, after surgery. But regardless, giving it first before immunotherapy, we know that's shown in trials to work well, good response rates. The immunotherapy, like you said, tends to work with well for certain types called biphasic and sarcomatoid. It works a little bit better for those more aggressive types. It can also, I've used it for epithelioid, but right now, in terms of guidelines, NCCN guidelines, cancer guidelines, it's not recommended to do immunotherapy as a routine after surgery and chemotherapy, because it hasn't really been shown we don't know how well it really works as a routine. We do know, though, it can be given if you have shown you've had surgery, you've had chemo, and then 2 or 3 years later, we see some recurrence. That's when it's been shown to be a benefit to improve longer chance of it coming back, or preventing it from coming back, taking longer time, meaning disease-free survival. It's better to give the immunotherapy then. So if you see disease, immunotherapy can be helpful then. And that's, kind of more tried and true, but not as just like, oh, we're just going to give you the immunotherapy as a routine without showing any disease. So that's kind of the nuance.
Okay, great. So just wanted to finish up with a couple of things. Um, One of the benefits of patients going to a place like Kaiser, in addition to being able to have doctors like yourself treat them, are the services, and some people call them wraparound services, but all the different ways that a place like Kaiser supports patients going through this. And so could you just talk a little bit about what Kaiser does to help patients and their caregivers navigate this incredibly complex schedule of appointments and visits and everything?
Right. So that is really a benefit for a system like Kaiser, and that it's similar to a system like the VA or anything that's got we call it integrated health. So what that means is All of your doctors, all of your hospitals, all of your nurses, all of the outside care, physical therapy, transitional care that you need, home health, it's all within our system. So you don't get farmed out to that different hospital, to that different clinic, to that, which is what we saw, for example, at the Brigham. Brigham was great because you'd come from Tennessee to get your surgery, but you're just coming to us for the surgery. You get your chemo and your radiation somewhere else or whatnot. So at Kaiser, you get it all within our system. So that's kind of the benefit. So you don't have to go far, and it's all within the same kind of network of doctors that have spoken to each other. So you get your surgery, then your chemo, your immunotherapy, radiation, all within network with all the same in the same different hospitals. You don't have to travel far, and all of that. And so that's kind of the nice thing. You don't get lost to follow up. You get, if you need to come in for labs because you're having a tough day, you just come in, you let us know. You come into our hospital. You don't go into an outside ER in Alaska, and then have doctors in Alaska not know what to do for you because they're like, what's mesothelioma? And so what big programs like the Brigham and have done, which is great, is they have what's called the Meso House, for example. So what they do for that, instead of, because they don't have an integrated system like Kaiser, where those patients, they don't let go home, but they have a hotel for them that's right next to the hospital, and they keep you there for 6 or 7 weeks, which they just got to understand. That's so nowadays patients don't like that as much. That's why it's even more important that I love the Brigham, and I think you should go there for your surgery, but not everybody lives in Boston. And gone are the days where people will want to live in a house right outside the hospital for 8 weeks. That used to happen all the time. That doesn't happen as much anymore. And they want to be somewhere near where their place is. So if you're in California on the West Coast, even if you think the Brigham's the best place, and maybe it is, it's not feasible to get all your care there, and you don't want to move there, right? So you do need to, I think it does help if you have a system where all of your doctors, your nurses, your hospitals, your radiology suite, your med onc suite are all in the same system. Now that's the benefit of Kaiser. Most places are not like that. So it doesn't mean that that's why you choose Kaiser, but it is a benefit, that we have in California, that it's all within network. There's no prior authorizations. Everything is covered. So that is kind of the difference and the nuance of that. Now, with that being said, if you're not Kaiser, then yes, it is harder to, while we can treat you per se, it is a lot harder to get into that system versus if you're already in that system. So that's probably a little bit more for offline discussion. But again, the benefits of having it all integrated. Same thing with the VA. At the VA, it's the same way. If you're at a VA in Tennessee, you could go to a VA, get transferred to a VA in San Francisco, and have all that covered because that's still within network. So, and the same thing with Kaiser. So my Kaiser Hawaii patients that have mesothelioma, everything's paid for them within Kaiser, and it's all still within network, if that may say so. That's kind of a nice perk, I think.
Okay. And just to wrap up, I know a lot of the mesothelioma surgeons like yourself often will talk about a patient's work history with them and how they were exposed to asbestos. And one of the other things, besides being super rare with mesothelioma, is it really only has one generally accepted cause of mesothelioma, which is asbestos exposure. And could you just comment on, in your experience, what the importance is of patients contacting a lawyer, trying to get compensation to make sure them and their loved ones are protected financially?
Yeah, I think that's the main thing. The reason why I'm a proponent of it, why it's good to, I think all families should get some type of lawyer, whether it's you all or somebody else or whatever. The whole key is that it is an aggressive disease. And most patients, well, every once in a while you'll have a long-term survivor. It's 23 years you see, but that's pretty much very rare. The majority, 95% of patients, will be gone within a couple of years. And because it's so aggressive, so what that means is you're not going to be around for yourself, and your family will undergo a lot of financial hardships, because I just told you it's the biggest surgery that we do. It's a lot of chemo, a lot of expensive immunotherapy, a lot of expensive treatments. Even if you have insurance, a lot of that traveling around to do a lot of things, it's a financial burden on the family. It always is. I've never seen it where it's not, no matter how wealthy you are. So with that being said, we know it is tried and true that asbestos some type, especially if you do have, not everybody has known asbestos exposure, but the majority you'll find out that they do when you kind of dive deep. So there's a nice cause and effect causal relationship with asbestos causing mesothelioma. It's a no-brainer to me. So you're doing it to help your family and your kids of all that burden that's going to come down the road. And we know there's a cause and effect, and it's one of the few cancers that we can say does. So to me, it's so important to do that versus if it was prostate cancer, for example, or even lung cancer. You can't necessarily say it's related always to smoking or like that. And so you're going to go through all that and you're not going to win because we don't know. There's a million different causes of different kind of cancers. Mesothelioma is the one you can say, this is tried and true. We know that's what caused it. You're going to go through hell with this disease a little bit. It is an aggressive disease. It causes a lot of symptoms. It's very costly just financially, but emotionally. And it's not, even if it's not financial cost, the emotional toll of mesothelioma of just suffocating yourself, meaning it literally starts to suffocate your lungs. You don't feel well, you don't eat, and you lose a lot of weight. You look very bad and you feel very bad. Whether you have family or not, but really it's for the family. I always say help your family out because this is something that emotionally is going to take a toll on your family as they go through this, whether they go through treatment or not. Even if they don't go through treatment, it's not an easy, it doesn't just, people think that you just die right away with this. It's not always like that. Even if you go on hospice, there's a lot of emotional toll. So to me, I think the compensation is really just a small thing that could go a long way, if that makes sense.
Thank you. And want to thank Dr. Velotta from the Kaiser system in San Francisco, California, for joining us today and offering your important insights on mesothelioma and mesothelioma surgery. And we look forward to having you back on in the future.
Yeah, happy to be on. Thanks, Joe.
Thank you.